Hello, I'm Deepesh Arora, founder of HealthOcta. My work has focused on building infrastructure in complex, fragmented systems, where outcomes are constrained not by clinical capability, but by coordination, governance, and access. Before HealthOcta, I built Gozo, a large-scale transportation coordination platform. Today, I'm applying the same infrastructure-first approach to one of the most persistent challenges in American healthcare: specialty access and care coordination in rural communities. I was born in India and have spent most of my time living in the US. With my last startup, the challenge solving for transportation in India was not a lack of providers, it was fragmentation. Thousands of independent operators, no shared standards, no coordination, and no data backbone. Gozo did not own any vehicles. We built the fabric: a shared dispatch, quality controls, pricing intelligence, and data infrastructure. That fabric scaled nationally, improved reliability, and created hundreds and thousands of jobs without central ownership. The lesson there was very simple and powerful. When you connect independent local actors through a shared infrastructure, the system becomes dramatically more capable without stripping away local control. That same principle applies directly to rural healthcare. Across the United States, rural healthcare systems face two deeply connected structural gaps. First, limited access to specialty decision making. Rural hospitals often transfer patients not because they lack the facilities, but because they lack the timely access to specialists who can confidently triage cases with adequate clinical data. Second, access and transportation barriers. A very significant portion of Medicare appointments are missed due to transportation challenges, driving avoidable costs, poorer outcomes, and inefficiencies across the system. Public funding initiatives represent a major opportunity. However, without durable, interoperable infrastructure, funding alone cannot resolve these systemic gaps. Now, telemedicine definitely expanded access, but most implementations stop at video. They often lack integrated diagnostic data, structured service-specific intake workflows, seamless clinical documentation back into the local systems, the local EMRs. As a result, clinical decisions are made with incomplete information, incentives skew towards defensive recommendations, and hospitals often relinquish clinical and financial control in this process. What rural systems need is not more virtual visits. They need infrastructure that supports data-driven clinical decisions, local governance, and accountability at a massive scale. HealthOcta enables hospitals, clinics, and community care sites to operate as nodes in a connected care fabric. Every participating organization retains full clinical governance, bills under its own tax ID, defines its own workflows, protocols, and escalation pathways. HealthOcta does not provide outsourced care. We provide the infrastructure that allows institutions to securely connect with their own specialists, contracted specialists, or trusted partner hospitals. The result is a federated hub and spoke network where care stays local whenever appropriate and escalation is intentional, data driven, and accountable. For example, a rural clinic captures structured diagnostic data, such as retinal imaging or cardiac vitals, which flows to a specialist for asynchronous review. Findings and documentations returned directly into the local system. A rural emergency department requests specialty triage from a partner hospital before initiating a transfer, reducing unnecessary escalations and congestions at the receiving hospital. Community care sites, including pharmacies, act as access points for screening and monitoring, supported by licensed clinicians operating with defined protocols. Clinical authority remains local. The fabric ensures clinicians have the data and connectivity that they need to make better decisions. Where access barriers persist, the fabric can optionally integrate non-emergency medical transportation coordination as well, using mature, proven technology patterns. This is not about adding complexity. It is about ensuring that care coordination translates into actual care delivered. This model aligns with the core priorities of public health and Medicaid agencies nationwide: local control and institutional accountability, workforce extension through connected care teams, technology modernization with interoperable FHIR ready data, measurable outcomes for oversight and reporting. Economically, reducing avoidable transfers and missed opportunities strengthens both the provider sustainability and public program efficiency, turning episodic funding into durable system capacity. Our approach at HealthOcta is not about centralizing care or replacing local systems. It's about equipping states and regions with shared infrastructure that allows local providers to collaborate, retain patients, and deliver high quality care closer to home at scale. I'd welcome a brief conversation to explore whether a focused pilot could support your region's priorities and inform broader system planning. Thank you for your time and for your leadership in strengthening healthcare access and accountability in your region.